Welcome back, kids and coaches. And today we are going to be getting into chapter 18, which is the shoulder complex. So let's get right into it. Now, with the shoulder, there's a lot of stuff going on here. This is a pretty complex system. You have only a few bones. There's really only 4 bones you kind of need to worry about. And that's going to be your humerus, your scapula, your clavicle, and your sternum. So your humerus is your upper arm bone. Your scapula is your shoulder blade, the clavicle is your collarbone, and then your sternum is your breastbone. So all these combine to make up what is known as your shoulder girdle. Now you have these little processes here. So you have your acromion process, your coracoid process. All these are pieces of the scapula that just jut out. They're just hooks that come from your shoulder blade, and they act as attachment points, really just for a lot of the kind of different musculature that goes on around that area. Now you do have 4 joints, only 3 real ones, and the 4th one is just kind of there. When you talk about the shoulder joint, you're talking about this right here, the glenohumeral joint. That is the actual shoulder joint capsule you're talking about. So if you take here, this is where your humerus or your arm bone would fit in. So this is your glenohumeral joint right there. This right here is a side view of it. So if I was looking at my shoulder straight from the side, straight through, and I took my arm out, that's what I would see. Notice how there is a lot of stuff going on here. So very complex. There's a whole lot of things going on in there. Your acromioclavicular joint and sternoclavicular joint both tell you where they are and what bones they involved just from the name. Sterno refers to your sternum, so your breastbone. Clavicular refers to the clavicle or the collarbone. So your sternoclavicular joint is actually really this right here. It's where the sternum and the clavicle meet up. Then you have your acromioclavicular joint. So again, clavicular refers to the clavicle or the collarbone. Acromio refers to the acromion or the acromion process, which is right here. So your acromioclavicular joint, you may also know this as your AC joint, is right here, connecting your acromion process to the clavicle. And then your scapulothoracic articulation. All this is where your shoulder blade sits on top of your rib cage. So there's nothing really attaching it there, but it sits right on top of your rib cage, and the ribs act as a guide to allow the scapula to move, or your shoulder blade to move. Now the muscles, lots and lots and lots of muscles. Even with only listing the important ones, you still have a lot of them here. So your big muscles that you have. You have arm muscles, chest muscles, and then back and shoulder. So if you can break them down into those kind of 3 basic categories, then you got everything there. Your arm muscles, biceps and triceps. Everyone should really know about those. Pec major, that is your chest muscle. So that is the major muscle you'd have there. Your deltoid is your big shoulder muscle. Now your deltoid has 3 heads to it. So you have an anterior one, a medial one, and a posterior one. So they form 3 separate movements for your shoulder. So one's in the front, one's on the middle, and one's on the back. Whenever you think of movement of any muscle in the body, the muscles move in the direction they're facing. So because the anterior deltoid is in the front of your body, it's going to move your arm to the front, or it is going to do what's called shoulder flexion. You can feel if you put your hand over the front of your shoulder and then lift your arm straight up, you'll feel a contraction in the front of the shoulder. That's because your anterior deltoid is moving. If you were to hold your whole shoulder and feel, you only feel the front or the anterior side contracting. Now, if I go to the side and I lift my arm out to the side like I was flapping my wings, now I'll feel the middle deltoid contracting. If I reach behind me, so if I move my arm straight behind me like this, which is called shoulder extension, then I'll feel it contracting in the back of my shoulder. So wherever the muscle is, it moves the body in that direction. All muscles in the front move your body forward. All muscles in the back move your body backward. Trapezius, or your traps, this is the big muscle that you have going from the base of your skull, and it goes all the way down to the bottom of your rib cage, and it forms a nice big triangle. Trapezius does not move the shoulder at all. It doesn't do anything moving the shoulder directly. What it does is it moves your shoulder blade. You cannot move your scapula without moving the traps. So anytime, without fail, that your scapula or your shoulder blade moves, your trapezius has to be working. Latissimus dorsi or latissimus dorsi, you may know that colloquially as your lats. That's this muscle right here. Latissimus means wide, dorsi means back. So the latissimus dorsi is your widest muscle you have in your back. Primarily, this is going to get you to pull your arms backward. Think about doing a lat pull down machine. You pull towards you. You are moving your arms backward. So your lats bring your arms into your side and move them back. Serratus anterior is this muscle here. It's spread across the first 9 ribs you have, and then it connects in at the shoulder blade. So it actually comes to the base of the shoulder blade here, but it connects on your first 9 ribs. It does 2 things. It is going to elevate your scapula, so it'll elevate it when you are going to, like, say, lift your arm up. So if I was sitting straight here and I lift my arm straight, that's just flexing my shoulder. If I lift my arm up to about 135 degrees now, my scapula is going to raise up as well. So it does scapula elevation. And the other thing it does is what's called scapula protraction. So if you were to sit flat or to lay flat in your back, you stick your arm straight out and then you jab. So you push out. This movement from here to here, that causes your scapula to move forward, or your shoulder blade to move forward. That is called scapular protraction. So that's the 2 movements that the serratus anterior does. It takes your scapula and moves it up, or it moves it forward. Your rhomboids connect your spine to the inside of your scapula. So your rhomboids, if you look here, so this is the inside edge of your scapula. They connect, and there's 2 of them. You have a rhomboid major and a rhomboid minor. They connect to your spine on both sides. So you have rhomboids that are on both sides of the spine, and then they attach on the inside edge of your shoulder blade and on your spine. What they do, because they attach to the spine and the spine's not going to move, they are going to bring your shoulder blades in. So they are what allow you to squeeze your shoulder blades together. So if you're doing a row, even if you're doing a lat pull down, anytime you feel your shoulder blades squeeze together, your rhomboids have to move. And then comes the most important but smallest muscles you have, your rotator cuff muscles. These are known as your SITS muscles, SITS, supraspinatus, infraspinatus, teres minor, subscapularis. These are 4 muscles that sit all around your shoulder that act on it to help move it in different ways. The supraspinatus is the one most often injured. It's also the only one that actually doesn't rotate the arm. But this is the one that if you hurt it, or if you hurt your rotator cuff, you're hurting this muscle. This right here is supraspinatus. It comes in the middle of your shoulder, so it goes underneath your clavicle and attaches on the outside of your shoulder. So it comes from the scapula, top of the scapula, underneath the clavicle, and then through down onto the outside of your shoulder. Because it's on the center of your shoulder, it pulls your arm outward. It's called abduction. If you abduct someone, like if you abducted a child, you kidnapped them, you took them away. If you abduct your arm, you take it away from your body. And that is what your supraspinatus does. The reason it gets hurt so much is because it has this very small hole here. And there's a lot of other stuff that actually goes in here. And that's why it gets impinged or compressed in there, causing it to tear. Your infraspinatus and teres minor both do the exact same thing. They both do external rotation, meaning they take your arm, and if I'm throwing a baseball, they're allowing me to bring my arm back. So they cock my arm. So if I were to hold it from the side, supraspinatus gets me to here. Teres minor and subscapularis get me to there. They rotate it backwards. Those two are right here. They attach on the back of your scapula, so they're on the back of your shoulder blade, and then they attach at the back of your arm bone or your shoulder bone. So the humerus, it attaches right in the back there. Your subscapularis does internal rotation. So what that does is when I throw, it takes me from here to here. So when I throw, this internal rotation movement is what my subscapularis does. Now the subscapularis is right here. It's located on the front of your scapula. So it is on the front side or the anterior side of your shoulder blade, and it attaches to the front of your arm. So the very front of your arm is where your subscapularis is going to insert. And again, this does internal rotation. Now, you have a lot of bursa sacs in your body. I know we've talked about these before. The subacromial bursa you have is the one that is going to be possibly injured the most. If you look at the bursa sac here, it's located right below your acromion process and sits right on top of your supraspinatus. If you get what's known as bursitis, that is inflammation of the bursa sac, you typically don't get that unless the shoulder or the rotator cuff is injured, specifically the supraspinatus. So when supraspinatus gets inflamed, it pushes up on the bursa sac, which then pushes against the bone, and the bone's not moving, and that causes it to get inflamed and it's painful. The other soft tissue you should know is your labrum. So the glenoid labrum, you have one in your hip as well, the acetabular labrum. That is this nice donut ring that is going to line the edge of your shoulder socket. This just gives you more of a suction cup to the shoulder itself. When you look at the shoulder joint itself, it's like you're having a golf ball sit on a tee. So if you notice, this is a ball and socket joint. Here's the ball, here's the socket. Except if you notice here, that socket is a lot smaller than the ball. It's exactly the same thing as what would happen if you had a tee and you stuck a golf ball on it. The golf ball is always going to be much bigger than the tee. This does two things. It makes the shoulder our most mobile joint we have in our bodies, meaning that your shoulder joint moves the most out of any joint you have. But because it's so mobile, it means it's inherently unstable. This means the only thing that is protecting you from your shoulder completely falling out of its socket is a bunch of soft tissue. So you just have tendons and ligaments that are holding that in place. There's no bones holding it in place. So you just have soft tissue holding that in place. Tons of mobility, very little stability. You could say your shoulder joint is living paycheck to paycheck. Now, a couple tests we'll look at here. This shoulder apprehension test. What you do is you would take someone into 90 degrees of abduction and then hold them here. You would hold your back hand against the back of their shoulder and your front hand against their wrist, and you would try to push them back into external rotation. If you had apprehension, so if I go to push there and I feel that my patient is kind of guarding or trying to flex that muscle to keep it there, or if they show visible signs of stress, that means they have instability in the shoulder. Not the inherent instability we're talking about, but something causing an injury there, meaning the shoulder joint is not staying in place. An impingement test. Impingement means you are squeezing something. If I impinge something, it means that I have put pressure on it, and when it moves, it doesn't have enough room to move without getting irritated or out having friction against it. Imagine, if you were barefoot and walking in shoes, like real, whatever, just even tennis shoes. The more you walk during the course of the day with shoes that are in bare feet, the more it's going to rub, the back of the shoe is going to rub on the back of your heel or around your Achilles tendon, forming a blister. Well, that same thing happens inside your body when you impinge a muscle, except a muscle doesn't form a blister, it just tears, and that's not a good thing. So when you are testing for impingement, you are testing to make sure that your shoulder has enough clearance inside of its capsule to be able to move without causing both pain or additional injury. When you do, say, the NIRS test, what you're doing is you are coming straight up here, and when I do that, I'm impinging that shoulder because my clavicle sits right here. When I raise my shoulder bone, so I raise that shoulder bone up, it pushes against the clavicle, meaning that it's going to have a lack of room for specifically the supraspinatus muscle when you do that. If I do the Hawkins test, I come out in front and go into internal rotation. Again, when I go into abduction, it's going to test that supraspinatus. And then when I come into internal rotation, it's going to test subscapularis. And then when I do the crossover here, this is going to give me potential for my AC joint. So that acromioclavicular joint, which runs from the clavicle straight to the acromion, you'll feel it because it comes, if you feel your shoulder or your collarbone and run your finger right over it, where you feel it dip down, that's where your AC joint is. Another way you could test the AC joint is put your hand over like this, so you have your elbow sticking out, and then the doctor would just push down. If you can't hold it up or you break, that means that you have a positive sign for a potential AC joint injury. The empty can and full can test. Both of these test your supraspinatus and infraspinatus. If I do my thumb up, that means I am putting my arm into slight external rotation to do that. So I go into scaption, and scaption means that if I went straight forward, that being 90 degrees, and straight to the side is 180 degrees. I go in the middle, which is roughly 135 degrees. That's your scaption. Thumb up, I would hold my arms up here. The doctor would push down on me, so he would push down just like this. If I'm able to hold my arm up without pain, that would mean my infraspinatus is okay. If I turn my hand over at that 135 degrees, same thing, that's testing supraspinatus. And then a sternoclavicular instability test, all that happens here is if you look for the sternoclavicular joint, so if you feel at the base of your neck, that's where the start of your sternum is, and you go over to where your clavicle begins, right here, where these two meet, that is your sternoclavicular joint. To test this, I would just push on this joint all four directions, side, side, up, down. If I get any sort of instability or pain there, not from just like the force of like hitting a pressure point, but if I get any pain there or any laxity between those two, I know that there's something wrong with that sternoclavicular joint. Same thing for the AC joint. You can do that exact same thing, except you go to the AC joint, you go push forward, you pull, or you push back, you pull forward, you push from the side, and you try to lift up, and you try to push down. Injuries here. Clavicle fracture is usually caused when you fall on your arm outstretched. So if I fell on my arm kind of like this, that could potentially cause my clavicle or my collarbone to fracture. This is very common in, say, like football players. You saw Tony Romo, who was the former quarterback for the Dallas Cowboys, broke his collarbone several times, and it's all because he fell or got hit in this position where he fell on his side with his arm outstretched. A humeral fracture, so remember, your humerus is the bone that runs in your arm, or your upper arm. This usually is only going to get injured from having, say, like a traumatic injury or like a say a car accident or blunt force trauma. However, you can get a humeral spiral fracture, which is this right here. It's where the bone breaks in the form of a spiral. So it's the fracture spirals around. This actually is somewhat common in left-handed baseball pitchers. Now, the mechanism of action isn't really well understood, but left-handed baseball pitchers are susceptible, and more susceptible than right-handed pitchers, to actually breaking their humerus or their arm bone just from throwing. And there's no real clear known pathway for it. There's not really a known mechanism of action, but it can happen. If you ever look up Tony Saunders, who was a pitcher for the Baltimore Orioles and the Tampa Bay when they were the Devil Rays, he did it twice. And I've actually witnessed this once. A guy I played baseball with down here in Phoenix was released from the Pirates. You know, he played, I believe he got up to high A ball with the Pirates. But anyway, left-handed pitcher, throwing pretty good, 88 to 92. I mean, all things considered, that's pretty decent. And we were playing at Tempe Diablo Stadium for a World Series game or a tournament game here. And he threw a pitch, and left-handed pitcher, he threw it almost into the first base dugout. I heard what sounded like a clap of thunder. Like it was just a loud boom. And granted, you know, since nobody comes to those stadiums to see adult guys play baseball, you know, it echoed. But it sounded like someone had, or something like caused thunder, or maybe like someone shot a gun. That was the kind of sound it made. Extremely loud. And I couldn't believe it, but all he did was throw his glove down and walk off the field. No pain at all. If you watch any Tony Saunders video, he is screaming in pain. But yeah, my teammate there did that spiral fracture. The next day he showed up just to hang out, and the entire back of his arm was black and blue. I mean, it was really gnarly looking. Now, shoulder dislocations, you can sneeze and your shoulder can dislocate. This is where the inherent instability comes. You look at someone like a Dwayne Wade, he dislocated his shoulder all the time. You know, it felt like it was just like a weekly occurrence for him. You always needed like a wheelchair to wheel him off too, because apparently when you hurt your arm, you know, you can't walk anymore. So that's the thing there. But most of the time you have an anterior dislocation. This means that your shoulder pops out in the front. So anterior means your shoulder would pop out going forward. A posterior dislocation means it pops out going backward. An inferior dislocation means it would pop down. That's very rare there. but most of the time you're going to get that. Usually this is the result of taking a hit on there. If you were blocking a shot in basketball and your ball hit the or if your hand hit the ball and they say the shooter was still shooting, that force could push that arm out, causing that dislocation to occur. Rotator cuff strains, strain is just, remember, a tear in a tendon or a muscle. Supraspinatus is most common, then subscapularis. Teres minor and infraspinatus are usually pretty good. When you move your arm out, so when you abduct your arm or raise it to the side, once you hit this about 60-degree mark up to about 120 degrees. So when you go from about right here to right here, this is called your arc of pain, meaning that if you have a rotator cuff injury and you move through this, you're going to feel it, because that's where the rotator cuff will become impinged, and if you impinge a tear, it's just going to cause more pain. Usually you don't get surgery for these. However, when you're something like a baseball player, especially like a baseball pitcher, usually you do get surgery for this because the outcomes are better, quicker, if you do that. Now, the major point where you can get biceps tendinitis, or where you can get tendinitis, is in the biceps, specifically the long head of the biceps. The long head of your biceps, right here, LHB, that attaches, or it actually goes over the head of the humerus and attaches in the superior labrum. So if we go back to this slide here on the labrum real quick, you'll see this here is your biceps tendon. If this was together, this biceps tendon would connect right here, and it inserts at the top of your labrum. This is very clinically significant. Well, I shouldn't say very, it is clinically significant, because if you get biceps tendinitis, you can in fact cause yourself to get a labrum tear just from not letting that to rest. Because if this gets inflamed, it pushes against the labrum. So you can injure the labrum just by having your biceps tendon injured. And really all these are your overuse injuries. You're not going to get biceps tendinitis just on a whim. It happens from overuse. So repetitive overhead throwing motions are the most common ways you do it. I talked about the labral tear. You'll see the acronym called SLAP. SLAP stands for superior labrum anterior to posterior, meaning that the labrum gets torn off of the bone from the front or anterior side to the back of your arm. This here is where your labrum should attach. This here is the labrum. You notice how all this is a gap. That is where it's separated off. To fix that, you tie it back down to the bone. So you use what are called anchors. You just get this sutured straight back to the bone. And that usually holds it in place pretty well there. We talked about bursitis. Bursitis is really just that inflammation of the bursa sac. Usually you have a tendinitis in there as well. And then we've been talking about impingement, but remember, impingement is just where you move the arm so you don't have enough room for the soft tissue inside to move. So if you get a tendinitis, that's going to inflame inside your shoulder, and when you move the shoulder, you create even less space in there, causing that to get more damaged. Typically, rest is your best thing to do for that, but you need to let tendinitis or bursitis, any sort of impingement-based injury, heal before really trying to start throwing again. So that is everything there I had for you for the shoulder. So a little bit longer of a video here today, but thanks for getting through that with me, and I will see you all later when we talk about the elbow.